Okay, my name is Freddie Ssengooba. I'm currently an Associate Professor at the School of Public Health, Makerere University. By way of additional introduction, I've done a range of studies looking at the health sector, published a lot on financing, on human resource and health systems assessment. I've also had the privilege actually to do my PhD focusing on this question of performance-based financing, which is being discussed today. So I was asked by Grace Kabenika from WHO to reflect on 3 questions for this meeting. But because I wasn't going to be available, I decided to record this video. I'll miss the interaction, but I'll try to explore if I can respond to questions through a Skype call. The questions I was given to reflect on are 3. One is Uganda health system ready for performance-based financing? The second is where is the fit between health financing generally and performance-based financing as a strategy? And where can we apply it if it doesn't fit across board? So these are the questions I'm going to reflect on in my talk. So maybe to start with, let me start by a few definitions, but I'm sure other speakers will have defined this, but for my purpose, I want to first of all say that health care as we see it in the policy and in the strategy try to address 2 main objectives. It has to ensure that there is good welfare of the population, but also it has to achieve social justice. And these 2 can be sometimes difficult to balance. And I think in my talk I'm going to try to address the balance between trying to achieve outcomes in health and health improvement, as well as trying to address the social justice and equity question. So when we talk of health financing, we are looking basically at 3 concepts. We are looking at how the government or a community or a country, for that matter, raises the money that is required to deliver care. How is it aggregated? And thirdly, how do you use to purchase services? And so in those 3 aspects, we actually try to achieve financing. The last one of purchasing is talking about how do you allocate this money around particular service, around particular processes, around the governance and administrative arrangements, which all together form the health programs as we know them. So when we talk of, again, health financing, there are some fundamental objectives one has to achieve. I talked about outcomes and equity, but also there is resilience. How do you ensure that the community has a system that they can go to every day going forward 20 years, they are sure that the system is going to be there and is going to continue to provide for them? Because that resilience is a key aspect of performance. Responsiveness, when they have unique needs, how do we ensure that those unique needs are catered for? Commonly talk of OPD, antenatal, delivery, child health. But when they need surgery, when there is an accident, what happens? How do they get connected? If they are getting care, how can we make it efficient? And I think the issue of efficiency has almost overtaken all objectives, partly because the advice we get comes mostly from economists who pay more value and airtime on efficiency and may not invest very much on the other aspects. And of course the issue of culturally acceptable services. How do we ensure that what is being provided actually is acceptable? You can be efficient by providing something that nobody wants to take. So when we talk of financing, these are all goals or objectives that need to be met. So when we talk of performance-based financing, there are 2 or 3 concepts there that I also want to quickly talk about. So we need to look at performance as a concept. So what do we define as performance? Most programs in this country, the ones that I studied when I was doing my PhD study, and a lot of programs currently on the ground, they choose and pick on a few things. Mostly OPD, antenatal care, deliveries here, STD management there, a bit of immunization here. So in general, they pick on a few interventions, and those are the ones that they monitor and measure. And out of that, then they say this facility has performed well, then we shall give it money. This one has not performed well, we will not give money or resources. But also the concept of performance is very important for us to appreciate in this meeting. Because sometimes we believe we talk about performance as if we are talking of a private entrepreneur. In other words, a business person who has set up his clinic and is going to provide care. That model exists, and we know we have private sector. But also there is a model where we have the owner is also government. And the people who are serving are actually not government, but employees of government. Meaning that those people are not like the other entrepreneur. They don't bring the drugs on shelf. They don't determine the people they are going to work with. They don't recruit the team that they are going to work with. They don't bring the right mix, because that is not your job. Their job, that job is assigned somewhere up. They also don't actually put in capital, because that is government going to bring that money. They also don't determine the medicines and how they come. So the kid today has the antimalarials, tomorrow they don't have. Today they have very few, the other time they have more. So talking to performance to these two groups has to be very different, because one is fully in charge, because he's the entrepreneur. Whatever goes on, he determines the profile of workers, he pays, he recruits, he puts the resources here. The person who actually is going to deliver care is just waiting to see what has been provided. His job is to mix that. So when this person here fails and this one fails, the interventions are not the same. Here the question is, are those resources required for the provision for these people who are serving on behalf of government have all that they need? Uganda right now, all studies that we see every day show that performance of frontline workers is not necessarily a function of frontline workers per se. Yes, they may have a contribution, but it's a composite. In other words, it is a corporate or co-production where you have many people contributing to the final outcome. So when you say that these people have failed here, you actually also mean that maybe the DHO, who supports them, has failed. NMS, who provides them medicine, may also have failed. Maybe the recruitment agents at the district and health service commission maybe also has failed. So when you punish these people for not performing well, my question is always, who are we punishing? Are we punishing the frontline provider for not doing their work? Or are we actually saying the system is the one that is not performing well, and therefore we should audit all the system upwards and be able to see where the performance failure lies, where are the drivers? Here you can say, okay, this is Freddie's business, you didn't immunize enough people, you didn't do this, so we are taking our money away, and you go away, that's fine. Now, so that is the concept of performance. It is not the same. I know that we listen a lot to economists who are not very much socialized in system thinking and public health, but I think we needed to, as Ugandans, when we look at the policy of financing this country and developing a financing strategy, we need to be very discerning about these issues because of what I'm going to say next. Now, where is this concept of performance-based financing come from? It is a concept that comes from economics. The idea is supposed to help operationalize efficiency, and if you are to do well in it, is that the performers will continue to be successful because they will continue to get the money and continue to serve. Poor performers, by default, they should ideally be phased out. In other words, get closed. That is what we call in economics competition, or law of the jungle. The strongest survive. So when you're in a rural setting and there is a health center 2 or 3 or 4 that don't perform well, and you keep closing them over the years because of performance-based financing, exactly what are we doing? My view is that actually we are punishing those communities and creating more access barriers, and we are going to make the concept of equity and social justice definitely unattainable. And over time, we are going to have a system which only serves the rich who are in towns where services are easy to provide, and those providers who are located in town are doing very well. And I think we should try to be very careful about the whole kind of ideology behind some of these interventions. So if you read any book about performance-based financing, that is the ultimate goal. Survival of the fittest. Is that what we want for the health sector or education sector, or for that matter, any social sector? My view is I think that is a misadvised concept going there. So, what does it take, or what does it take to actually have performance-based financing in a country setting? Some of you will have heard of Rwanda is doing performance-based financing. Cambodia has been there for years. Haiti was there even in the early 80s. And in between there have been countries, especially countries that are coming out of conflict. Afghanistan, Rwanda, Haiti, Cambodia, and now all these recent countries that are like Iraq. You find a lot of literature from there. We should ask ourselves, why is it that the literature we read about this concept is from conflict-prone countries? The point is, there are no states there to function. So you have ideally to get private actors quickly to deliver care, and it is the tool that you can use in those settings is ideally performance-based. You dangle a carrot, and you get mobilized from all over the world and come and deliver care, and once everything is settled, they pack their bag and go. But if you are to build a health system that is resilient, resilience requires that you use models that are going to make these systems stay beyond and over the short term. How do we ensure that in a Gulu or either where there have been wars in the past, Konya has been here, how do we ensure that actually we construct systems that can stay long and be there than just to say, let's have this NGO come here for 3 years, they get money, they run the program, everything looks nice, but after 5 years, everything collapses. And then you get another grant, another NGO comes, starts from zero. You can't construct a system on that kind of approach. Then let me go now to the issue of the main, what I say. I'm going to start off by, of course, raising much of the problems, and then I'll come later to share with you where I think this might work in a limited setting. So when we have had several performance-based financing projects in this country. You know, some have been run by World Bank and Ministry of Health with the PNFPs. That was 2003 up to 2007. We had one with Maristops, again with World Bank, working in the Western Uganda, looking at STIs and management of pregnancy, antenatal, and all that. We've had, now we have some in Northern Uganda. I think it is supported by DFID. Through USAID also we have some focusing on family planning. Now all of these are being evaluated, and also in many countries there have been these evaluations. But what is interesting among the literature that is coming out, there was a systematic review by a colleague of mine called Sophie Ritter, and that review is available on the Cochrane website for systematic reviews. Now that is a study that looks at all other studies that have been done, but the conclusion in that is that there is very weak evidence to show that these mechanisms work. I want you to look at it because it has a lot of references that are very important for you to look at. It was published in 2012. But also the studies that we've looked at, and I've had the privilege to be a review on many of them, authoring some of them, and reading, of course, in the field, because this is an area that I've spent a lot of time. One fundamental question and gap in there is, which is very much surprising, is that there are no cost-effectiveness studies. What do I mean? People are talking about how it works in Rwanda very well, how it works in Bangladesh, how it works, but they've never actually tried to say at what cost is this working. And why I said it's surprising, because all these studies are done by economists. Actually, most of them are financed by World Bank. And if my friend Peter Quera is in the audience, he might want to explain this. Because all studies World Bank does, the first question they put is how cost effective is it? But for PBF studies, that is the question that no one has addressed. And if we are, as a country, want to go into result-based financing or performance-based financing, I would want you to find a good study that tells us how much money has been used for what results. Because if we look at that, we realize that we may or may not be doing the right thing. My quick answer is they are not cost-effective. This is not a cost-effective intervention, especially the designs that we've had. Why? Because you find there is about 5 or 4 agencies are outsourced to. So there will be a grant from DFID, it is passed to World Bank contracts, let's say Maristop's contracts like 4 other agencies, and now those agencies go to Western Uganda to do service delivery. Then they contract somebody to distribute vouchers, they contract somebody to educate the community, they contract somebody to audit, they contract another agency to do quality assurance. What is left now to deliver STI and delivery services is almost 20% of the total grant. The rest is taken by contractors, meaning that the administrative costs of these projects are so high. Now, you can say as a country, let's design one where we don't have all those subcontractors. But one of the fundamental aspects of PBF is that you need to actually audit the performance before you pay. So you must have some way to audit. But auditing in health is very hard because not 2 hospitals are similar in the way they deal with care. Some people elect to go to Mulago because that's where they can get good surgery. They will want to go to Mbuya. And now when you come and compare the two, you realize that definitely Mbuya will always have lower costs because they don't deal with complicated cases. This one is dealing with complicated cases. Auditors are not very much suited to measure the characteristic of care and how much care is required in that setting. Although everybody will come in as a road traffic accident. Someone will come in near death, another one will need a bandage. But the diagnosis may be road traffic accident. Now you can go and do like what the US did and say let's categorize these diseases and give them different payments. So mild accident, moderate, severe. But when we read the American literature, and is that actually doctors there have figured out that the best way to make money, you record everything as severe because you get more money. Right now, a lot of people are writing about how America is sicker because of they spend more money, but they're the sickest population for that level of payment. And the reason is simple. The incentive that the financing strategy is doing in Americans is to make them look sick. Not that people are sicker, but the doctors are paid to indicate that people are sick. Now, what is the implication locally here? If we are designing this thing without a good oversight and careful insights, we are going to mess up all the data systems because we will cease now to be able to tell the disease profile of this country because people are now going to start writing diagnoses that brings them money. And that, I think, is one of the enduring challenges of performance-based financing in countries where it has been started. But when is it necessary? Or where can it be useful? In Uganda, we have short-term interventions where we need results within a short time. Let me give you an example of the National Child Days. We want to kind of immunize, let's say, 7 million children across the country in about a week or 1 month. Now, in that sense, you can say, let's use performance-based financing for this effort. Because, you know, within a month or so, that intervention will be done. There will be a way to measure that district has achieved 20% or 80% or 100%. Because the measure is generally somehow built into the system. It's not very hard to get. and it is standardized. Everybody is giving the same vaccines, everybody is giving the same tablets, so you can actually put everybody on the same scale and measure their performance. So in that case, you can use that method. If there is another similar approach where again you can achieve a level of standardization, but also a level of auditing, which can be routinely collected without spending so much money, again that can be used. The other example I can think of in that regard is if we talk about, let's say we're trying to distribute nets or mosquito nets across the country. And so we have 7 million to be distributed, and let's see how they've been distributed and reward the distribution. Because then you can know that 60 households coverage has been reached there, 20 here, 80 there, so you can actually use that. If it is a spraying household with the residual spray for mosquitoes, again, those are things that are easy to measure because you have a system either at community level or within the health sector to give you the performance audits, and then you can make the payments. And it is one-off. Why I'm insisting that it should be one-off is that if you are going to pay routine things with incentives, you run out of the incentive effect. If I'm going to be working in this clinic every day, and this month I'm paid because I've made targets, the following month I'm also paid because I'm paid targets, by 4 or 5 years down the road, you may find that now you have to look for a lot of money to keep going up with the performance. It's called the rocket effect. Now, that's not sustainable in a country like ours. And as we know performance, the moment you change the incentive and say, oh, we've been paying you like this, but now we can't afford, we are going to stop, then we'll be actually getting the whole system going down because of trying to get people to be motivated by money and then trying to make that behavior to be driven by money, but we can't sustain the growth of that money. So I think from those two examples, and I believe in the meeting you'll find a lot of other examples, there is a role for performance-based financing, but this role has to be limited to short and periodic outcomes or goals that we need to achieve. But for configuring the whole system of delivering care for Ugandans, for every day, for the long term, we need to make sure that social justice and equity is guaranteed. And what does that mean? That means that even in Karamoja, where people are moving with their cows, there may be very few people coming to health facility. We have to put it there. Even if that nurse doesn't see a delivery in a month, you can't close it. Because when eventually delivery comes, you should be able to deliver that child. To say that we closed it because it was inefficient, now only services are available in the urban centers and in Kampala where the population is big, I think we as public health people will be fooling ourselves. And personally, I wouldn't like to be in that kind of environment. But I believe that the people assembled in this room today may not agree with me totally, but they will find some things I've said to agree with. So going forward, I believe that we need to step above the basic facts that we are getting and the ideologies that are being pushed. We need to examine those ideologies and see whether our health system actually should be built on those ideologies. And if we see big gaps that don't resonate with our goals, we should not be shy as technical people to actually design our system according to our ideology. And that is the message I want to give you. Thank you for listening to me. If opportunity of technology allow, I will try to see if I can be on Skype to respond to questions, but otherwise I will ask the organizers to share with you my emails. I will definitely respond to questions and look forward to opportunities in the future to continue this dialogue. Thank you very much.